You're listening to the St. Louis Pain Expert Podcast with Dr. Dave Candy, St. Louis's leading expert in chronic pain relief. Dr. Candy specializes in helping women age 40 and above to overcome chronic nagging aches and pains without medication, injections, or surgery, so they can stay active, mobile, healthy, and independent. Whether you're suffering from pain yourself or know someone who is, pain's a universal experience that affects us all, but that doesn't mean you have to suffer. Knowledge is power, and having the right information can help you or someone you love get on the road to recovery. On the St. Louis Pain Expert Podcast, Dr. Candy talks with other pain experts from around the world to give you the information you need to recover, the peace of mind of knowing that you're not alone, and the hope that lasting relief from chronic pain is possible, and it doesn't require relying on pills, injections, or surgery in order to do so. So sit back, relax, and open your ears, mind, and heart, and let the healing begin.
Welcome to the St. Louis Pain Expert Podcast. I'm your host, Dr. Dave Candy. I'm here today with Dr. Matthew Gaunt of Optimum DPT in Petoskey, Michigan. And Matthew, thank you for joining us today. Can you tell us a little bit about yourself and about your practice and the kind of people that you help?
I'm a physical therapist. My practice, like you said, is out of Petoskey, Michigan. It's kind of the upper northwest, northern Michigan. It's a fairly typical outpatient, orthopedic, your muscle injuries, joint sprains, strains, arthritis, post-surgical care, that clinic. But I also see a healthy number of patients who are dealing with chronic or persistent pain.
And that's kind of what we had approached you about. And I know you deal with a fair number of people who are either stressed or anxious and deal with chronic pain. And, can you tell us a little bit about your kind of stereotypical patient who has chronic pain? Not that they're anyone's stereotypical, it is kind of their own individual case. But, tell us about the kinds of things that people come in to you complaining about and what they're suffering with.
Yeah, I mean, there is no 100% stereotypical patient with chronic pain. It can be young kids to, octogenarians, 100-year-olds that can come in with chronic pain. And it can be various different positions or not positions, but places and locations in their body that are having chronic pain. I see a lot of chronic neck and back pain, chronic headache, and like jaw pain are some of the more common locations that people come in where they've been having pain for months, years, decades. But as far as if I was to say this is the most common type of person to come in, it's going to be probably a woman, middle-aged, someone that maybe a little overweight with high levels of work-related stress or home stress. And usually they've got a history of like anxiety and depression and just a kind of a high kind of a mental and emotional load on top of the physical condition that they're dealing with.
And that does, at least demographically, according to the research, people who are more anxious, more stressed, there's a big association of that and chronic pain. Women tend to be more than men. So, that's a lot of the same type of conditions and people that we deal with at our clinic as well. Can you tell about, some of the things that they've gone through before people, finally make it to you and, what things they've tried, what has worked, what hasn't worked, and, what solutions you offer for those people that you said who have been suffering for years or decades even?
Yeah. Usually before these patients have made their way to my clinic, they've tried just about everything under the sun. They've done, massage care. They've been with other physical therapists. They've tried chiropractic care, acupuncture, oftentimes more than once. They've been to multiple other providers trying the same treatment. They've been worked up by their physicians. They've been on the XYZ medication. They've done injections. They've been referred out to, neurology, to rheumatology, to orthopedic surgeons for surgery. They've gone through the gamut. A lot of times they're in or have been through pain management and they're just, they're either continuing with it or they're giving up. So more often than not, I'm kind of end up being the last stop for the vast majority of them. Occasionally I get someone that's been in, much earlier on that journey, but I think that tends to be the case with a lot of therapists who are working with persistent or chronic pain population, that they've just tried everything. Most of the time, those treatments are the right thing for your subacute and acute conditions, but not for the chronic and persistent pain cases.
And, just for the people who may not be 100% familiar with the differences between, what acute and subacute mean, can you explain a little bit more about, what would be like an acute pain versus chronic pain?
Yeah, I mean, so acute pain is, that's bending over and feeling that twinge of back pain right there. That's stepping off a curb and rolling your ankle. That's in the moment, within that instant to a couple of days, maybe a week. That's acute conditions. And then subacute's that phase, okay, all the inflammation's gone down. It's been a couple of days. It's been a week or two. And now, tissues are healing up. It's that period of a couple weeks after an injury or an onset of a problem to a couple months out. Once you're 3, 4, 5, 6 months out, that's when a condition has gone from that acute, subacute into this chronic or persistent issue. Usually, depending on some factors, but tissue will heal up 3 to 6 months. Some of the more slow healing tissues, 6 months to a year. But you would not expect an actual injury to be there and continued for longer than that. And for patients with persistent pain, long after the tissues knitted and healed up and scarred down, they continue to deal with symptoms. So that's the difference between a chronic or persistent issue versus a kind of a fresh or acute injury or a healing injury that's subacute.
And so, by the time it's gotten to the chronic pain, you said the injury, so to speak, had pretty much healed. What about people who come in with bulging discs or herniated discs or things like that on their MRI?
Those will also heal in time. There's some excellent pictures that you can just Google, healing bulges. Even those tissues, they don't have great blood flow, so their rate of healing is slower. But when you take a look at a nasty kind of herniated bulging disc on an MRI, and then take a look at that 3 months, 6 months, a year later, the body will absorb it. It's not, it's not as quick as like a cut on your skin, but your body will absorb it, take it back, kind of eat that material up, and you'll go back to looking, from a really nasty, scary looking MRI to one that's pretty darn fresh and clean looking. So all tissues heal, just it takes some faster than others, but if you've got a pulse and a heartbeat, you've got the ability to change, heal, adapt, and get better.
That's encouraging. Yeah, I think a lot of people, when they've been suffering for a year or 2 years or more than that, they actually kind of lose hope that they feel like healing's not possible. But you mentioned that within a year or two, even a herniated disc will heal. But what about people who have gone on longer than that? People who have been 5 years, 10 years, 20 years or plus that they've suffered. How do you help those people?
Yeah, I think my take, and I think most therapists who are treating persistent and chronic pain will tell you that the emphasis is needs to be placed more on the nervous system. That it's basically the nerves, the spinal cord, the brain itself has adapted to being in pain, and now it's wound up. It's no longer about a tissue issue, but it's about these nerves being just extra sensitive and more apt to say, hey, we've got a problem here. And then that danger signal from the area that was having a problem getting transmitted up into the brain that much more readily because of how the nerves have been running and getting really good at sending that signal. And the brain agreeing and saying like, yes, we do have a problem here. I'm going to project pain into that area and make it super sensitive and sore. And so the emphasis is on the nervous system. And I think that's where the treatments need to be focused on for this patient population. That's not to say you're not treating their musculoskeletal and you're not treating their muscles or bones or joints and whatnot. Of course, you're doing that. But that can't be the only focus of treatment. It needs to incorporate that. Otherwise, they're just spinning their wheels with doing those treatments that we talked about, the massage, the chiropractic, the standard traditional physical therapy, or the interventions from physicians.
Now, when people hear that they say that a doctor says the pain, your brain tells your tissues that they're hurting, they sometimes feel like they're saying that they're being judged or feeling like they're being told the pain's all in your head. Do you ever have patients who have been told that by people in their lives? And how do you kind of explain that nerve approach with the understanding that their pain is real? They're not making it up.
No, absolutely. And that is something you hear a lot. And I think there's, growing up, from like various coaches or maybe family members where they say like pain's mental and whatnot. And that kind of strikes them. And then here they're dealing with this issue that's incredibly nasty and debilitating and could be really life affecting. And then maybe they go into a healthcare provider who is trying to take them in this direction, but does it with a little lack of finesse. And that's the takeaway message where they were said, I guess I was told by Dr. XYZ that this is all in my head and it's not real. And it's nothing's further from the truth. I mean, every patient's pain experience is real to them. To the extent that it's in their head, well, that's where the brain's located and that's where the nervous system is centered. So, and that's where the changes from persistent pain take place, at least in part. I mean, I'll tell patients, well, it actually started in your spinal cord, right there at the little dorsal horn. We'll take out a little, anatomy. We'll do a little bit of a neuroanatomy lesson. It's like, here's where the dorsal horn is. Here's where all these changes started to occur. And here's this little neuron, this little inhibitory neuron. And because of all the nociception, which is your danger signals, coming in from this initially injured tissue, these are the changes that happen through here. This is where this signal, which should be getting blocked, is now getting a fast track up into the brain. And the brain, it has changes. Instead of being a crisp, clear image of your body, that representation starts to get a little bit blurry. It starts to smudge. And now your pain, instead of being really specific to this one spot, starts to spread. So, like say it's someone's wrist issue. Well, now it's in your hand. It's up to your elbow. That makes perfect sense. And here's why. And I think once patients understand that it's not a voluntary thing, it's a subconscious thing, it's something outside of their control, but it is real and it is happening. That's where it clicks and they are able to recognize it and realize that there is this. And then, the technical term for this is neuroplasticity, and it can happen in this detrimental direction, but it can also be reversed and happen in a much more, therapeutic, favorable direction. And then once that happens, patients realize that there is hope and there's stuff to be done for it.
So just to kind of clarify some of the technical terms, you were mentioning about the dorsal horn in the spinal cord, and how that actually, it sends, for a given amount of input that your system's giving, it sends more information than maybe it needs to up to your brain for a given situation. And then, an analogy that I use a lot with my patients, and I'm not sure if this is what you were describing, but your brain really makes good rational choices based on the information it's given, just it's not really given information by your spinal cord that's reflective of reality.
Yeah, like the the little metaphor I'll give it is like that part of your spinal cord should be like a good offensive line blocking this incoming signal, but instead it's gotten lazy and it starts to be more like a matador and just goes olay, and then up it goes. So no, it should be. It is getting a disproportionately strong signal from the area, and with that misinformation, it's then making a mountain out of a molehill in a lot of cases.
So once people become aware of that, there are things that they can do to get that system to work better?
Oh, absolutely. Absolutely. And that, that it really depends on where the individual is, as far as how sensitive they are. And for people that are, super, super sensitive, they come in and, they're just extremely guarded. They don't want to move the body part. Let's say it's a neck pain issue and you like turn or crane your head and you see them wince and flinch, or they, are so sensitive you can't really even touch that part of their body. Those patients will definitely benefit from that type of education, but then also low level treatment, which can be as simple as like breathing and mindfulness exercises. That can be huge for somebody who's been in persistent pain for a while. And then you have your two different types of nervous system. Most people have heard of like the sympathetic nervous system, the fight and flight nervous system. And when people have been hurting, for weeks, months, years, that part of your nervous system is super jacked up. And breathing, focusing, getting the diaphragm working, will really help calm that part of the nervous system down and then trigger the other one, the parasympathetic, which is your rest and digest nervous system. And just doing that can change people pretty profoundly. I mean, like resolve the issue completely, no, but it might take it from a 9 down to a 6. And from there, we can start with other treatments and get them moving, and then help reverse some of this. So, that's just an example of someone that may be coming in that's super sensitive. That's would go to another provider and they're like, I can't do anything. You're too hot to handle is one of the common phrases in that patient population. But even for someone like that, that's just one treatment that you can do with them. It's pretty simple to start off with. They can have a profound effect.
Yeah, on the extreme end, you're right. There can be some presentations that seem just so overwhelming that if you just look at it from, I have pain in my shoulder and my back and my knee and my elbow, and it moves around from one place to another, it can be really overwhelming. But the fact that you can just recognize that, we don't need to treat shoulder and knee and back and elbow and neck and whatever else I said, but that we're treating the same system. It's great that you recognize that. Now, how did you actually learn about all this? You're obviously very well educated. How did you kind of get all this information, and what really got you into treating people with chronic pain?
For me, it was really the postgraduate education that I went through. So I did a postdoc fellowship program, or orthopedic manual physical therapy fellowship, which is, in my opinion, is kind of the highest level of education you can go through after residency and whatnot. And it was there that I really got it. Before that, there wasn't too much exposure. I think it was in PT school, and my initial years of practice were just before the kind of the treatment of persistent pain revolution kind of happened. So it was in that fellowship program where really I had some great people in my cohort who were really well versed in the treatment of persistent pain. Specifically Sean Flanagan and Justin Dunaway, and they're just really great. I mean, Justin is on faculty with the Institute of Clinical Excellence now, and he teaches the whole pain science course with them. And then our fellowship coordinator, Ray Butts, is an amazing PhD in neuroscience, and he's just a truly dynamic. So like sparked this interest in it, for me. And then it was like, okay, I took that and I took back and, I'm not sure how your fellowship was, but we went through these intensives and we take it back and then start to apply it in clinic. And I had this 80-year-old lady with shoulder arthritis. And it was in my shoulder. They won't do surgery on me because my heart's too bad. I just need it replaced. I can't lift my arm up like this. Every time I do, it's like gravel. And I'm like, all right, so let's try to work this. I was like, yes, I realize it's kind of gravelly and whatnot. I can feel it there. I did, definitely recognize that as an issue. But is your other shoulder hurting? No. I was like, well, let's move that around a little bit. Oh, it's kind of noisy too. It's got a little bit of that arthritic gravel going on in there. Do you think that's the issue then? And then it was like a kind of light bulb moment for her. Like, hey, this shoulder's been through the exact same stuff my other shoulder has. It's got the same kind of quote unquote wear and tear in it, but it's not hurting. Why should this shoulder hurt? And we went through it. We went through the neuroscience education, and then she came back in and she was like moving her arm freely. She's like, is it hurting you? She's like, no, it stopped. It went away. I was like, well, and that was kind of a light bulb moment for her. I was like, oh my, there is a lot to this. And from there, it was a lot of self-study. I went back to look at kind of who the innovators and pioneers in the pain science field were, like Louis Gifford, David Butler, Lorimer Moseley, Peter O'Sullivan, Adrian Lowe. And I was like, okay, what are these people doing? Where have they been? And what can I take and use to the best of my ability? And then from there, it was just a lot of just refining, because it's not easy. And there was a lot of cases where I don't think I did it well, and probably left a lot of people thinking like, oh, this guy just thinks I'm making it up. But over the weeks, months, and years that followed, it got a little bit better, a little bit easier, and it helped a lot more people that way.
It's definitely a skill to be able to take that sort of clinical knowledge that you've learned from your training and bring it back to real people who are suffering. But it is wonderful when you see that light bulb click and people get it, and suddenly they go from, I'm just old, I've just got arthritis, to, hey, there's a chance for me, I can get better. And then even better, they come back the next time and they're moving their shoulder like they probably were 10, 20 years ago. So that's amazing and fulfilling and wonderful. And I think that's really, at the end of the day, why we're both in the professions that we're in, to see those outcomes. So that's great that you're able to provide those to people. Kind of going back to the people that you see with chronic pain, what other things have they tried in the past, and what treatments do you provide, or what do you do that's just a little bit different than that?
Yeah, I mean, I think, I think in the past they've been through your traditional, we'll call it like biomechanical care. So they've been through the doing the soft tissue work, or the joint work, or traditional muscle strengthening and endurance exercises. What I want to say that I did, let's just say, it's like how I go about treating patients who present this way and who have this condition going on, would be to start with that what's kind of referred to as pain neuroscience education, where we take them through basically how pain works, not necessarily an anatomy lesson, but like this is literally what's happening in your body. This is why this is going on. And then specifically as far as treatments go that they probably haven't had elsewhere, it's kind of on a spectrum of how sensitive they are. Like I mentioned a little bit ago, like someone's super sensitive, we might just start off with breath work, so breathing exercises, getting their diaphragm, trying to trigger that parasympathetic nervous system. And then from there, we might go on to looking at somebody move that body part. Let's say it's their shoulder. Watch videos of people moving this. So, and you think like, okay, what's that doing? But when you're seeing that, you're actually triggering the movement part of your brain that recognizes and do that. And it's like getting some mental reps and seeing people move in that way, in a non-threatening kind of easy, gentle movement is actually a form of treatment for them. And once they're fine with that, we may actually begin, working on, what's called like left-right discrimination exercises, or laterality is the technical term for it. So that's people who are, have been hurting for a while. They lose the ability to discriminate like the right side from their left. And we may work on that. So like, what part of the body is this? Is this your right hand or your left hand? Is it your right leaning or your left? And that's pretty simple. And then from there, once they've got a good handle on that, we may start doing, like visual mental reps. Do you see yourself doing this? Do you see yourself, going through that? And that's, that's something that athletes will incorporate for better and easy movement. And it's pretty effective for, patients dealing with persistent pain. Once they've done that and they're pretty comfortable there, we may start introducing a mirror box, which is where they, if it is an extremity, they can put the injured or the painful extremity inside a box and use that reflection. And it's kind of a little, we'll call it like a Jedi mind trick, where they're seeing their non-involved side move free and fairly independent, and that will actually lower their pain levels. And they're getting mental reps of, hey, here's this damaged or problematic tissue, and now we're moving it freely and easily without pain. Pain levels go down, and then once they're comfortable and once we're moving out of that, I might actually use some if they're dealing with what's called disuse atrophy, where that limb has withered somewhat. I may add BFR on if that's pretty comfortable. So it's blood flow restriction therapy, which is it's a pretty easy way to prompt strengthening without adding lots of heavy weight on. And people can get great function back without having to do heavy load. And as we move up the spectrum, it really starts to look more like traditional care at that point. But we just pay a lot of attention to their tolerance and capacity for exercise. Like I go through with everyone the concept of like a pain threshold. So when you feel your symptoms getting to the point where you're overstimulating yourself, that's the point to stop. We want to work out at that threshold, to it, but not through it, is one of the big phrases I think Adrian Lowe had coined. And we want to respect that. So it's just, as we're moving up, it's created activity, created exposure and pacing so that we're never overstimulating them, but we continue to challenge it. And eventually, at the end, it's really indistinguishable from the care that they did in the past and was not beneficial for them. So it's just a gradual incline, and it's never a straight shot. There's always ups and downs, peaks and valleys. But what I'll tell patients is like their valley at the end is going to be so much higher than their peaks that they're just going to be amazed at what they can do, what they can tolerate, and how much they've gotten their lives back.
So it sounds like the big difference is that, for people who have been through traditional care and almost quote unquote failed, people say, not necessarily failed, but the treatment hasn't worked for them. And people who have had unsuccessful prior care, maybe the level was just too high. And so you start them down at a lower level and then bring them back up to that. Is that kind of a summary of what you were saying?
Yeah, it's the right treatment at the wrong time. It's great care for that, what we were talking about, that initial and healing phases of injury. But for someone whose nervous system is super wound up, it's just far too intense for them. It overstimulates them, and they just end up bouncing where, they're going to go do something. It just overcooks them. They spend a couple days feeling absolutely miserable. Then they come back down to normal, or they're normal. And then they're like, everyone I think has had that, where they progress someone a little too fast and they come back in. They're like, I don't know what you did, but I spent the weekend just miserable. And you look at them and there's no signs of tissue damage. There's no bruising. There's no swelling. There's nothing that suggests that anything was actually injured, but we just did too much, too fast, too soon. Okay, that's informative. Now we can back it down a little bit. How about you try this? How about you try that level? Or maybe we back off a few minutes and see how that goes. So it's a slow process, just gradually building someone back up. climbing a mountain slowly.
Yeah, I think a lot of people, when they think of exercise, they think, well, if I'm going to start exercising, I got to go do 20 or 30 minutes or an hour of exercise. And, it's not an all or nothing that, maybe for someone it's 5 minutes, maybe it's 3 minutes, maybe it's mental reps for someone who's really sensitive, like you said, and just, visualizing exercise is taxing enough for them in really severe cases. It's just about finding the right starting point for the right person.
Yep. You find where they're at, and that's where you meet them. And I think that's one of the important things for those patients. And also to really listen to them. Like a lot of times, especially in our modern healthcare system, I mean, you get like minutes with a physician and then they're out the door onto their next patient. These people have been hurting and suffering for so long. They want to be heard and they never feel like they get the opportunity. And that's one of the keys, like right off the bat, is to take the time to let them tell their story, to let them really communicate everything that's been done. And that in and of itself can be super therapeutic.
How much time do you typically spend with a patient?
I never rush someone that's dealing with persistent pain. It could be, obviously as brief as like 20 minutes just going over their history. But I've literally had patients who have spent the full hour talking with me, just going over everything they've been through, everything they've done. I let them know. It's like, okay, we're kind of running out of time here. We may not get everything done today. This may have to continue next time. But I've never really had a patient get angry about that. They're like, I can't believe you just spent this much time with me going over this with me. That in of itself is just super helpful. So, on the long end, probably about 90 minutes. Like I've had patients go the full hour and then come back in and keep going. And like, oh, let's do some little tests and measures here. See where you're at as baseline. We can start working on this too. But I think a lot of patients just benefit from having that ability to talk. And it's, that's one of the things like we have, I think better than I can't think of another healthcare profession that gives as much time to their patients as, physical therapists do, by and large. It's just wonderful to use that or have that ability to use it too.
Yeah. We'll typically spend an hour with people too. And it is interesting sometimes when you do actually spend that full hour just listening to people. And, kind of in your gut, you feel like, oh gosh, I really didn't do anything. And they get up to leave your office and they say, thank you. I feel so much better. And you're just honestly being a sounding board and not cutting someone off. It's really something that it makes a big impact. So that's awesome. Kind of in closing, what are one or two pieces of advice that you'd give someone who may be listening to this that might be dealing with chronic pain?
I think, a lot of these patients who have been dealing with this for months, years, decades, kind of give up. And that would be, they're just in that, I've got to accept this. This is life. This is me now. And that is not the case. So don't ever give up. Like I said earlier, if you're breathing and you have a pulse, your body can adapt, and you can get better. And the other piece of advice is, the best time to have started care was, yesterday. And the second best time is today. So basically the sooner you can get in and get treatment, the better it is for you, to get back to living the best life that you can. So don't wait if possible.
Well, thank you, Matthew, for taking the time to spend with us today. If there is anyone kind of in the Upper Peninsula area who's listening to this and may want some help, how would they reach out to you to get some help for you?
Sure. I mean, I'm available by phone. Phone number is 231-881-9770. And I also have a website, OptimumDPT.com. It's got a lot of information about the conditions that I commonly treat at my practice, as well as persistent pain. And there's plenty of ways to contact us or send me an email, and hopefully get you some help.
Well, thanks a lot. We'll put that information in the show notes so people can access it if they need it. I really appreciate you taking time out of your busy schedule to spend with us. So thank you, and enjoy the rest of your day.
No problem. Thank you. Have a good one.
You too.
Thanks for listening to the St. Louis Pain Expert Podcast. We hope you've enjoyed the show. If you live in the St. Louis area and would like Dr. Candy's help to find a solution to your pain, visit our website at stlpainexpert.com. Email Dr. Candy at dave@stlpainexpert.com or call Dr. Candy's clinical practice, Movement for Life, at 314-941-3970. Movement for Life offers free consultations called discovery visits to people who are serious about discovering how they can relieve their pain and get back to the happy, healthy, and active lifestyle they deserve. If you're listening from outside the St. Louis area but would still like some help, feel free to contact us to learn more about our virtual health coaching. Regardless of where you live, please share our podcast with anyone you know who would benefit from learning more about pain and what can be done to relieve it. And don't forget to subscribe to our podcast on iTunes, Google, Spotify, or your other favorite podcast platform so you get notified when we release a new episode. Thanks again for listening, and we hope you'll enjoy us again soon.